Okay, fine. And I go by Durnin just to make matters simple. I know my name's a mouthful. So just to clarify that, I'm coming to you as a physician who works in the trenches in addiction in BC, and I've done so for almost 20 years. So my perspective is going to be more qualitative. You've heard a lot of science. I am going to say that I endorse a lot of what I've heard from previous speakers, and I've been sort of in and out all day, so I haven't heard anything, everything. But for example, what Dr. Humphreys says, what Dr. Reed alluded to, what Dr. Summers alluded to, and so forth. So my experience is different. I work right across the spectrum of addiction. So I work with individuals in harm reduction, and by that I do not mean safe supply. And I work right with them through the whole spectrum of recovery, right up to individuals who are in full recovery, leading productive, quality lives, and are so happy to be doing so. And there is a huge spectrum of in between where people are on repeated cycles of recovery and relapse, and their stories are just as important here. But if I get nothing else through to you in this few minutes, what I would really like you to understand out of this, that recovery is possible. It is not an elitist phenomenon. There is a perception, I think more so in this province, that recovery is restricted to those who have, unlimited resources and so on. That is not necessarily the case. To give you a perspective on my background, I have worked in the downtown east side of Vancouver for many years. I've worked in correctional settings. I'm working in a private recovery center, the Orchard on Bowen Island. I also work in occupational health settings where we have an extra tool to help people get better when they want to keep their jobs. It's an incentive. And also on top of that, I serve on the board of Vision Quest, which is a recovery society nonprofit, which takes individuals mostly out of correctional settings, in fact, and helps them in long-term recovery, and it does so on a shoestring budget. So the message I would like you to hear is that if you can direct the resources towards more recovery, as opposed to what has been traditionally done in this province, which is harm reduction, I think you have the opportunity to make great changes here. We are talking mainly about safe supply, and the perspective on that. So I want to get back to that. And I want to tell you a story about one of my own patients, because even though I've been working in addictions for a while, I didn't really understand this until I was working in the downtown east side of Vancouver. I had patients that had been addicted to oxycodone before in family practice, and I'd seen lots of stuff when I was working in a HIV setting. But when I was working in downtown east side in about 2008. And this was just when the oxycodone crisis was brewing, but we didn't really understand until a couple of years later. Back then, there was a terrible event where there were 8 overdoses in one weekend. At that time, that was a tragedy, right? Now that would be great, but now, back then, that was a tragedy. So what we did, we had notices up in all of our rooms, and we said, there's some potent stuff out there. Please be careful. Please don't use alone. Come and talk to us, all the usual stuff. So my patients would come in and they would talk to me and they would say, they would, do the usual stuff. And I'd find them looking at this notice and I'd say something to them. They go, and they'd get out. And finally, I had one girl come into me and she said, she stared at that thing and she said, could you take that notice down? And I went, well, hang on, we're trying to save people's lives here. We're trying to make people feel better. And she said, I see that notice and all I want to do is go out there and get some of that stuff. And for the first time, I actually understood how someone in addiction thinks. They do not think like normies, which is what they would call non-addicted people. They think, the more potent, the more better, the more I want it. And so that concept has been born into me time and time and time again by my patients when they come in to see me. It is no accident that right now, out there on the streets of the downtown east side and in Surrey, where I work now, that people will overdose. The rescuers will come up and Narcan them, and these are people who are on the streets themselves. They will Narcan these patients 2, 3, 4, 6 times because that's what it takes with the potency of this stuff. And the first thing those people ask when that person comes around out of their overdose is, where did you get your stuff? So this is something that we need to understand, is this is how people think. There will never be a more potent opiate than that we can make that is greater than what the dealers can supply. It's like a game of next better than, better than, better than. They will always top it. And that was just borne out to me last week. I had one of my patients come out from the downtown east side, and I said, is it still as bad down there? And he said, it's worse. So right now, they are giving out what are called hot flaps. And hot flaps are really potent opioids that the dealers are giving out free to certain patients because they know those patients will use them, they know those patients will overdose, and they know that everybody's going to want to know where they got their stuff. That is the reality of what you're dealing with, and that's why safe supply can never be enough for these people. I will read you out a statement that is from the Opiate Use Disorder Practice Update, which is recently put out in British Columbia, and it contains 2 statements which I find to be a complete, contradiction in terms. It says, the statement reads, it is recognized that every dose of a safe supply reduces the risk of overdose. But in the same paragraph, it says, many individuals may continue to use a combination of prescribed hydromorphone and illicit opioids. And that is what you've heard from other presenters, 90% or more will continue to use potent opioids. And we know that it only takes 1 grain of carfentanil or the also potent U-477-000 that are contaminated in these things deliberately by the dealers to knock somebody out to overdose. What is the point? Conversely, as you have also heard from other presenters in this field, you have heard that these opioids are being sold and redistributed. You heard this from Dr. Reeb yesterday and others. I have patients who have told me that they are selling their safe supply. It is literally being put in Canada Post by drug dealers and shipped out east to Newfoundland. A colleague told me yesterday that the same thing is happening with pills being shipped to the Yukon through Canada Post. So, and again, they're being sold for much higher. Somebody is making a lot of money out of that, and our government is paying for it. The irony is that the people who could really speak to you, and I wish they could speak to you in this, are the people who are actually in recovery. And those people will tell you more authentically than I can that they would never sanction safe supply if they were in their addiction. They know exactly what they would do with it, which is what I've told you. But the irony is that those people who are in recovery have to keep quiet, and you're not hearing from them. I have asked some of my patients to speak out to you and to put their comments in the comment section for your committee. But again, if they put their own names to those comments, they are in fear of either being censured by people, either other people who don't understand, or by people in harm reduction who believe that they are against harm reduction in general, which is not the case. So I want you to understand that. I also want you to understand that on the other spectrum, and there's everything in between, which we can talk about, that recovery is possible. It is done every day. It does not have to be super expensive. To give you one example, the board that I serve on the board of Vision Quest, and I just learned yesterday from their executive director that they operate on a shoestring budget of, I think it's $35.90 per client per day. And that is compared to $60 per day for a shelter bed. So they are struggling, but it doesn't have to be that way. And if more of those resources were diverted towards recovery, I believe we could do much better. I realize I'm out of time, but I would just like to say that with respect to those people who are in recovery through the fact that they have hooks through their work, that they have to remain so, it's another tool that we have to help people get better. And I would really like to stress that this is not just for people in high-powered professions like health professions or pilots or that kind of work, but also for people across the street, construction workers, laborers, anybody that we can bring into the fold and bring into what we call contingency management, which is where people have incentivized to do better. This has better results in my population. And the last thing, if there's time to say, the clinic that I work in, that I started with Dr. Mulama, that you're also going to hear from, we started that as a therapeutic setting with harm reduction where people could feel safe to walk in. We did not prescribe and never have done safe supply. We do consider buprenorphine and methadone harm reduction that brings people into a safe environment where we do wraparound care and provide them with a safe place, a trusting place that when they feel ready, they can talk to us about recovery without judgment. Okay, and I think I'm going to stop there. I don't know where my time is up, but there is a lot of stuff to go through, and I'll let you ask if you want more.
Thank you, Dr. Durnin, and for your passion and work with those struggling with addictions. Thank you for that. We will open it up now for Q&A with the members, and we'll start with MLA Milliken.
Thank you, Chair. Thank you, Dr. Durnin, for your presentation here today. Again, the passion comes through. I've got one question that's almost a bit of, I would almost call it housekeeping for myself, and then another question that I think is going to get flushed out, or I might be able to ask if given the opportunity. One thing that I just wanted to, you've got obviously a lot of on-the-ground experience with regards to this, everything that we're doing with this committee. People are, those that are on safe supply, it's my understanding that they would be over time developing a tolerance, something that I don't think we've heard on the record yet, but I think you may have kind of almost alluded to. Those who are providing safe supply, would they be increasing the potency given to the individual with an OUD over time?
Do you mean what's out there now or what is being proposed?
What's being prescribed right now on the ground, say in East Van? If somebody is is receiving it, whether it's from a vending machine or anything along those lines, is it being increased over time as they stay on the program?
Well, that is the natural course of opioid addiction, is tolerance for increasing amount of opiates over time. To give you an example, I was talking with a physician who works in Vancouver General, and it took something like 600 micrograms of fentanyl or something equivalent to that to stabilize one of their patients who came in aggression and psychosis. And by the way, one of the things I did not touch on in terms of the downside of safe supply is the provider burnout and fatigue from dealing with these individuals on top of everything else. But that is 600 micrograms of fentanyl is a phenomenal amount. I mean, to give you a comparison, if you started someone who is naive to opiates on 12 micrograms, they could overdose. So yes.
Thank you for that. What is on the ground? How are people or providers, such as doctors, how are they determining how to ramp that up? At what rate? And what I'm looking for is a lot of what we've heard from people who have OUD is they are out there going for some illicit substances in order to self-medicate for their own needs, what they have. Are people, like, I'm just trying to get at, like, what are the parameters for the doctors prescribing to increase over time? And is there any kind of data flushed out there that if that does continue to be increased, that there is some sort of stability? Or do we see a situation where it's tough to get that right, individuals go out on their own and potentially would experience some sort of lethal or non-lethal overdose?
Well, The fact is that in the first place, as you know, and have heard, people are not using safe supply without also using illicit opiates by and large. So which is doing what is somewhat hard to tell. That being said, I don't quote me on exact numbers because I haven't looked at it recently, but my impression was something that people were being allowed to prescribe, and that was within the judgment of the physician, up to about 14 8-milligram pills of hydromorphone a day. That is roughly 500 milligrams of morphine. But I have seen people getting up to 30 pills a day. They've come into me being prescribed that. And my understanding was that there was an earlier document put out by the BC Centre for Substance Use which referenced ramping up the potency of opioids to fentanyl, et cetera. That I think was subsequently retracted. So that is I believe, on the table potentially in the future right now with no clear benefit.
Thank you very much. And if I could,
Go for it.
given your experiences on the ground, and you kind of alluded it, to the issue of drug diversion in that last response, do you know of any processes or policies that could decrease drug diversion?
Well, no, there is just a complete atmosphere of standing back and doing nothing right now in this province. I do not know of anything, and I think the answer to your question is what Dr. Humphreys said. Is like he's just explained that to you, that limiting the supply of opiates is the only thing that's going to reduce this demand and the diversion.
MLA Stefan.
Good morning. Thanks for your presentation this morning. One of the things that you raised, and I really appreciate your perspective, is that safe supply can't compete with unsafe supply because those who are suffering under addictions are not seeking more safe drugs, they're seeking more potent drugs. And market forces by drug dealers are seeking to provide that demand. The question that I have is we see the government in your jurisdiction, BC, notwithstanding this, they seem to be pursuing safe supply type policies. And I'm wondering, why are they doing this in the face of the fact that safe supply is not what those who are suffering under addictions want?
You must remember that people who are getting safe supply have, a vested interest in continuing to get it. So that's the patients themselves, because they will sell it and divert it for more potent opiates. They may use, and I've seen a couple of my patients doing this, I'll keep a pill in the morning so I stay out of withdrawal when I wake up until I can go get more potent stuff. But the answer to your question, why is the government doing this? I don't know. I can only assume that there is pressure from sources or a belief that without the evidence that this is a better way to go. You heard Dr. Matthew, I believe, yesterday speaking about the 4 pillars of treatment of addiction treatment, which are prevention, harm reduction, treatment, and law enforcement. And we seem to be sitting on one pillar, which is harm reduction. For example, in the downtown east side, you can look, there is an open market for stolen goods, and the police literally just sit back and don't even go in there. We're past that point. And so there is very little law enforcement, unless they have to go in there and intervene. And we have very little treatment. As I've told you, it doesn't make sense to me that a recovery community could be getting less than $36 a day from the government when a shelter bed is getting $60.
MLA Yao. Oh, sorry. Supplemental.
Yeah, just a quick one. You had mentioned the 4 pillars and that the BC government seems to putting emphasis on the harm reduction pillar. Do you feel that there's a hierarchy of pillars in terms of public good? for both those who are suffering under addictions and their families and the communities they live in?
I think that nobody wants to see people go to jail because they're addicted to drugs from the law enforcement point of view. We want to see something along the lines of the Portuguese model. Okay, so from that point of view, I would say that law enforcement is not that priority in that sense, but I see all the other treatment modalities as being equally protective. For example, one of the criticisms that is leveled, which is in favor of safe supply, is because a lot of the overdoses happening were for individuals who were using alone at home, and that's fair comment. But I would say that the answer to that in the long term, and it's not a short-term solution, is prevention and education. None of which is happening to my experience here at the present time. So we have advocated to the government, myself and others have tried to advocate for change. We haven't seen it yet.
Emily Yao.
Thank you so much, Chair, and thank you, Dr. Durnin, for appearing before us. I was just wondering if you could expand or clarify your comments regarding shelter beds and the economy of that, the economics around that. And the backgrounder is some previous guests and speakers have maintained that providing things like shelter, the safety of a shelter, food, clothing, things like family and peer support are proven things that facilitate recovery and should be emphasized. Is that what you were getting at, or am I way off base?
No, I absolutely agree with those comments. I think that, again, I think referenced Maslow's hierarchy of needs and so on, and that's absolutely true. You can't really talk to a homeless person who's using drugs about recovery when they're out in the street that night, right? It's just impractical. But what is happening is, in my experience, is that people are being siloed. If there is any housing, they're thrown there without any visible supports. I've talked to support workers who have left in frustration from shelters like these. So I have no problem with shelter beds, et cetera, if it's part of a well-organized community. You've heard the term recovery-oriented systems of care. This is the work of William White and John Kelly. It's in the literature. And it is also, it's a very viable concept in terms of how to organize the recovery landscape from harm reduction up to engaging people. Shelter beds are part of that. What I'm saying is that it's kind of ironic that we can give that to a shelter bed when we can only give about half of that to someone who's actually an organization trying to promote recovery.
Yeah, thank you, Chair. So based on your experiences working with, government agencies and whatnot, that addiction is a complex issue, and that governments seem to take a very one-dimensional approach to rehabilitation and support for this, when they should probably be more of a coordinated effort with like a housing agency, like BC Housing as an example, with their social services, with the addictions and mental health agencies. Is that fair?
Yeah, for sure it's a complex issue, but it's been done in other jurisdictions. It's being done in other areas. And I think that it can be done here. I think if we keep digging ourselves into the hole, the first thing one should do is stop digging and start to turn around the ship a little bit. But it can be done. Yes, we will not see the results this year or next year, but down the road, you will start to see the numbers drop. And to one of your other colleagues' earlier comments, the overdose rate in BC has gone up in the last 2 years with safe supply. It was over 1,700 deaths last year, or the year in 2020, and I believe 2,200 over 2,200 in 2021 so far.
Emily Milliken.
Thank you, Chair. You had mentioned in your presentation earlier that you had been encouraging individuals who have experienced recovery to come before the committee or to share their experiences. And then you had stated that they had felt like they were being silenced or pressured to be silenced. This is kind of getting into a little bit of, I guess, perhaps hearsay. So I guess as a member of the committee, I would give it the requisite weight and value based on that as like a premise. But if they were invited, you've obviously had interactions with some of these individuals. If they were brought before this committee, what do you think they would say?
I can tell you that those individuals have a perspective on what it is to be living in addiction as opposed to living in recovery. And they can tell you hands down where their lives may have gone had they not gotten into recovery. They can also tell you how someone in addiction thinks and why it would be perfectly normal for someone in addiction to want to continue in safe supply, which is what you have heard from other people as well. You must remember, think of this as a brain disease. We know that we can put this disease into remission, but it can take 2 or 3 years for that individual. Therapeutic communities such as San Patriano in Italy take people on with the commitment of 3 years because we know it takes that long to change their brains. So how can you expect someone who is in active addiction or in early recovery to resist the idea of using using pills if they're available and handed to them? The other corollary I would say that those people would ask, and I'm talking about people who've had the support of getting back into the workplace, is that in early recovery, people really need to know that they are supported by their community, by their government, by their workplace in getting back, because it's a crucial part of recovery. To give you the example, my patients in Alliance Clinic, where I've been working, often will go to recovery for 2 or 3 months. They come back out and they're suddenly having to go back to 12 hours a day jobs because they've got to feel their family. They're in construction, they're in labor, they're in non-technical jobs, and they need to go back out and feed their families. They're under stress. They can't carry on with the support work they need to do. And I would reference you to my earlier comments to the Standing Committee on Health in 2014 into the House of Commons, in which it incorporates some of the aspects of recovery for people coming out of the early stages, where, as Dr. Reed mentioned yesterday, there is support for people, say, to work half-time initially so they can continue the recovery work, so they can take additional training, so that they can be accountable in their recovery. That is what I think those people would tell you.
No follow-up, but I just do want to take the opportunity to thank you for your response. I know how difficult it can be to sort of speak on behalf of others. I think that when it's brought to my attention that certain individuals are feeling silenced, that worries me. We've gone above and beyond with the opportunities to bring everybody possible to this committee. So I want to take the opportunity to thank you for that response. Thanks.
Thank you, MLA Amory.
Thank you very much, Chair. Good morning, Doctor, and thank you very much for being here as well. I echo, I think, on behalf of all my colleagues, how important this discussion is, and so I thank you for your time. I'm going to go over some of your earlier presentation, if I may, and forgive me if some of it overlaps some of what my colleagues have already asked, but I do think it's important to get it on the record. You began by saying that recovery is possible for all and not restricted to the elite, and I think that was an excellent segue in what I have to ask you about here today. In your presentation, you then continued by saying unequivocally that safe supply can never be enough for those suffering from addictions. You then moved on in your presentation to suggest that, and I think it was a quote, forgive me, I don't remember who you were quoting, but it was suggested in that quote that safe supply reduces overdoses. I think we've heard multiple times from you and in our own considerations, some of this might be a little bit dated now that you've covered it, but one of the strongest arguments in favor of safe supply is that it does, according to the proponents, reduce overdoses. Don't know how accurate that statement is. I think you've clarified that with respect to your comparison of the BC situation over the years that you provided us with, but even if it were, and as tragic as overdoses are, I know that's not the only metric that we need to consider here. We need to think of things like societal and interpersonal and family damage that is caused, health and economic consequences, for example, and countless other impacts of drug abuse. My question is this, it's a two-part question. I'll ask them both at the same time in the interest of the limited time that we have. Are you aware of any credible evidence that supports the notion of safe supply of opioids, the safe supply of opioids, my apologies, do in fact, with all other things being equal, reduce overdoses? I know that there are complications with the pandemic right now that may have impacted the BC numbers that you've quoted, but all things being equal, I wonder if you can comment on whether or not there is evidence to suggest that safe supply jurisdictions do have reduced situations of overdoses. And then finally, and regardless of what your answer to that is, what other consequences, whether positive or negative, are safe supply jurisdictions dealing with, and how do they compare with other non-safe supply jurisdictions when it comes to the other metrics of drug abuse in a society?
To your last part, I'm not quite sure what you mean by other safe supply jurisdictions.
I'm asking if you can... Sorry?
Do you mean in like in Ontario or whatever?
Yeah, Ontario, BC, and non-safe supply jurisdictions as they compare to one another.
Okay. I cannot speak to the other jurisdictions really. What I can explain to you is how first I have no evidence, as other speakers have said, that harm reduction, that safe supply has had a positive impact on anything respecting overdoses or et cetera in this province. Secondly, to give you an idea of the impact, as I said, I work in Alliance Clinic with Dr. Melamed, and we work within that clinic with the full spectrum of people, from harm reduction patients right up to recovery patients who are coming off methadone or Suboxone in many cases. But within that population, we have seen a decimation of those who are in sort of active addiction at the time of safe supply coming out. To be clear, we will prescribe methadone and Suboxone for people because we will engage with them that way. They will come to us, and before so-called safe supply, that was our hook to have them come back into us. They would take methadone, Suboxone to stay out of withdrawal, and then we would then engage with them. And that's what I call harm reduction. They might continue to use other substances, or including fentanyl, but they would come back to us to get back on methadone or Suboxone, and eventually we would wait and hope, and in some cases they do want to engage for the next steps. With safe supply, that kind of went out the window. Many of our patients scattered, many did not come back, a few did. They are basically either lost to follow-up and we're not getting the new patients to replace them, because now on the street, you can get anything, anytime, anywhere.
Excellent. Thank you, Dr. Durnin, for your time. That does conclude our time for question and answer, and sincerely appreciate you taking the time to be able to present us today. So thank you for that.